prostatic artery embolization and when is it needed?
So prostatic artery embolization is a minimally, or rather say very minimally invasive therapy or technique in which what we do is we close the prostatic artery, or we embolize or block the prostatic artery. So it can be done in any patient with benign prostatic hyperplasia where we don't want to go for a higher surgery or any surgical resections. And
why is prostatic artery embolization better than conventional modality of management?
Conventional therapy, first of all, we need a surgery. So any surgery needs anesthesia, and any anesthesia has their side effects. Second thing is with the conventional surgeries, there is always a problem that is seen is with the sexual disturbances. So it's almost like a daycare procedure without any surgical scar, without any surgical trauma, and without any much of the complications.
What is your clinical experience and present literature evidence on this procedure?
We have done embolizations for malignant masses which cannot be resected, and our clinical experiences with these are the patients are relieved very fast. Like patient sometimes come with a gross hematuria, and we do a prostatic artery embolization and patient's hematuria is relieved. Patient comes with a massive BPH. So one setting of prostatic artery embolization, it softens out the prostate, the patient's symptoms are relieved, and within a month or so, he has a good amount of relief from the symptoms or issues, and prostate size is also significantly reduced. So there are multiple studies which suggest that prostatic artery embolizations, the results are really good. They last for 3 to 4 years and even more depending on patient to patient, and they are in favor of prostatic artery embolization as a good alternative to any other surgical therapies for the prostate.
What is radial approach and how is it beneficial for the patient?
Patient can undergo any puncture from the radial artery, and through the radial artery that is in the hand, we can just take the catheters. There are new catheters, the longer catheters are available. We can hook the internal iliacs, we go into the prostatic arteries and we can embolize them, or for any other where we can do these procedures. So radial approach is now growing up because in the femoral approach, what we have to do is the patient has to lie down for around 6 to 8 hours, immobilize his hip joint. Even if we use closer devices, then also we give them a rest for around at least 4 to 6 hours minimum. In radial approach, the patient can go home, continue his work and living, and with just a simple radial band or radial compression, and it's like very convenient for the patient.
What is your message to the general physicians about managing these patients in their OPDs presenting post-procedure?
There may be some mild dullness or dull pain or heaviness in the pelvis because of the embolization. There might be some pain. So these things can be very well managed with the simple medical conservative management. If the patient is having some anxiety, they can be given some anti-anxiety drugs, anxiolytic drugs, or mild painkillers and reassurance. That's good enough.